Yeah, I mean, some other things we've already kind of touched on, I think, is, a new APP doesn't really have a good grasp on, what their limits are, what patients they should be seeing on their own, when they need to get a physician involved. Did you have anything to say about that, or do you feel like we covered it?
Yeah, I think I've worked locums quite a bit early in my attendinghood just because I wanted to be scared. I wanted to know that I was all there was as a resource. I wanted to either crash and burn or have to learn and survive to be efficient at just about everything you could get efficient at, because I feel like in this specialty you need to be second best at everybody else's specialty. And I'll tell you, working locums out in the middle of nowhere is one way to do that. And I think after having done that, I get that was the steepest learning curve doing locums work, which they don't typically recommend to patients, or new doctors straight out of residency. And that's what I did for the first couple of years. I think that's the feel that probably a new PA or NP has coming out of school, and knowing I have a scope of practice this big, I have a knowledge base that I don't know how big it is yet, and I have this world of things to know. So I get the feeling there. I think that it's good to remember this is a team sport, the ER. This is absolutely a team sport. It takes a village of people to care for some of these patients. And so the need to ask for help, to get a physician involved early, to bounce it off your cohort if they're the only one around is fine. It's going to, I've had nurses ask questions where I went, oh shoot, I hadn't really thought about it that way. I've had, NPs and PAs come up with genius ideas or do a better physical exam than I had time to do and say, hey, did you think about X, Y, or Z? It takes so many eyes on some of these patients to get to where you need to go. Mm-hmm. The idea should be it's okay to call for help. And on that same note, for those who decide to go work rural, we have, previous partners from our group that have gone to work in, other states and rural communities on their own. And there's not doc oversight unless you're on the phone. That's its own animal, obviously. But to know that if you have a question, to set your ego aside, to be not so nervous about how gruff is this physician going to sound at 1 a.m. or whatnot. If I need to get on the phone and call a tertiary care center and say, I don't really know, what do you make of this? Mm-hmm. So be it. It takes a village. So I can't emphasize enough how it should be welcomed by all to want to involve other practitioners, to ask for help, to learn something new in that moment, to get a perspective of that patient that might be different than yours. And the more often that you have people who have practiced longer than you or have had a bigger scope of practice than you, making a reference mainly, I guess, to MDs versus PAs, the longer you have, the more times over time that you have interactions where you go, that's exactly how I was thinking about this, and that's exactly how I approached that. That's great. As long as you keep in mind that you'll never catch it all, you'll never know it all, and you should always be willing to ask for help. Getting other people's opinions, ideas, and involvement early is just a must. Mm-hmm. It's a must. It just takes such a team to care for a lot of these folks.
Yeah, and I think the groups that do it right are the ones that cultivate that relationship and make it easy to, I feel very comfortable going to any of our physicians and saying, hey, I don't know what to do with this patient, and not every environment is that way, and so it's a lot harder to involve a physician, but I think the right places, make that relationship as easy as possible, because it's better for the patients, and it makes a much more team and easy environment to practice in. I think working as a team is super important.
And that's something probably to look at for a new career choice. You may not have a choice. You may need to live by location or paycheck because of debts, things like that. I get that. You may need to take the one job fresh out of school that is available to you where you're at. I get that. But if you have choices and you find an environment where you're like, these are my folks, I can talk to them, this is welcoming, I don't feel like people are waiting to test me out or dump all the workload on me, or they're hard to approach, that is a huge part of this job, and burnout from the NP and PA side that I hear is it's hard to adapt to these personalities. If you find a place like our group, I feel like 95% of the time you're going to be totally comfortable running to whoever's on and saying, I have a question. Look for that. Look for that in a job. Yeah. That's the environment you want to be in.
Yeah, absolutely. Yeah. Our system's a pretty high volume system too. Not every system obviously is that way. Everyone's going to be practicing in different environments, but I think as a new grad, you got to start with lower volume. You just cannot handle 1 million patients in a shift, and you've got to make sure you know where your boundaries are and not take on more patients than you can handle initially, and make sure you're seeing the patient from start to finish and not just seeing them and writing an HPI and doing a physical exam and then hours later you've realized, oh, their workup's back, I need to make a decision, I'm not sure what to do with it, and completely lose the whole disposition part. I see a lot of new grads kind of struggle with that part when they're taking on too much volume. So I think it's a good idea to really watch that initially and kind of grow your volume as you gain experience.
Agreed. On that note, I think there's something to realize. If you're a physician in a lot of environments, you have no real backup for the volume of patients that hit you. For example, if you're a solo doc in one department or in an entire shop, it's you. If the patients keep coming in the door, they need to be seen. They need to be reevaluated. They need to be followed up after their labs come back. They need to be reevaluated when their vital signs change, and then they still need to be dispositioned in an efficient time. I mean, it's all you. One of the huge upshots to realize that is a good thing for NPs, PAs, and other practitioners is that you have a team and you have a doc. If you feel like this is borderline unsafe, I just saw 4 patients in an hour, 2 of them are sick. One of them, the nurse says something just changed and I should go back to the bedside, but I don't have a disposition for everybody yet, and I'm not where I want in my charting right now, and I'm coming up on the end of my shift. Speaking of things that'll burn you out, being there for hours after every day, doing things like that. If you're not where you want to be with the volume you have, that is a huge benefit to being an NP or a PA. The doc is responsible for that entire everything at once. It's okay that you're like, hey, these last 2 patients in an hour make 6. I can't get there.
Yeah.
So be it. That's a huge plus to the position. So do the best with what you've got, and you'll get better over time. But if you're panicking, I've seen that plenty of times too. Hey, I made rounds, all these ambulances showed up at once, and I managed to see all 4 of these. And then as a doc, you look over those patients and you realize 3 of them were absolutely nothing. They're not emergent by any means. One of them was real sick and probably should have had somebody stay at the bedside for 15 minutes, and they're not there. And then I'm managing the rest of the department as well. It's okay to say, hey, this one's really sick. These 2 don't sound bad. I need some help right now. It's a team effort again.
Yeah.
So work with what you can work with and let that grow. That's the right approach.
Yeah. I see a lot of our job as figuring out all the patients that are not actively dying that can wait a little bit to find the ones that actually need your immediate attention and most of your focus. And so I think a lot of our job is you're triaging. You get 5 or 6 ambulances in an hour. You've got to figure out which ones need your attention and which ones can wait a little bit. To prioritize.
I think on that same note also, there's some stress that comes down towards APPs or PAs, NPs. There's some stress that rolls down because you hear so much coming the doc's way about metrics, disposition times, and do things in this order. Anyone who can go home needs to go home before the next one's seen if they're stable, and turn them this color on the board that shows that we think they're going to be admitted because it stops the clock. That's a nationwide thing, all of this. This is not specific to our group. All these metrics that bring stress on the doc don't have to roll downhill. It doesn't have to sit on the NP and PA as well. If you stop thinking about clocks and time frames and things like that and worry about good patient care, let the doc worry about all that other stuff. You can mention things ahead of time. Hey, this patient, I just really have no doubt in my mind, is working their way towards admission. Okay, you can voice that. You don't have to be in charge of, per se, stopping the clock on all these patients. Those metrics are what really bring an extra level of stress to the job. That doesn't have to be owned by an NP or PA. Let that stuff go until you're as efficient as you're going to get.
Yeah. Another point that I was thinking about is when we're involving consultants, right? We consult all the different specialists on a daily basis, sometimes on every single patient. I think a good habit for APPs to get into is talking with the physician before they call up a consultant. Now, after you've got some experience and we've got to involve this specialist, I think it's fine to just call them. But when you're new and you're not sure what the question is that you're asking the specialist, I think it's a really good habit to talk to the physician first and be like, what am I actually asking them? It's not enough to call them and give them the whole story and just say, what do you think? You should have a specific question for them, or, hey, I need you to see this patient during their admission, or I need you to see the patient tonight, they can't wait. There should be kind of a goal. And with weird imaging findings, if you're calling surgery because you're not sure, well, did you ask the physician first to review that imaging finding? They might know exactly what this weird thing is that the radiologist is describing that you've never heard of. They probably run across it a handful of times, and they know if you need to involve a surgeon or not. And we do get complaints from specialists sometimes with that kind of stuff. So what are your comments on that kind of thing?
Yeah, I have a couple of comments about all of that. Consultation is a trick to this specialty that a lot of other subspecialties don't have to deal with. It brings a lot of added stress, I think, both to docs and PAs, everybody, because you never know the personality type, the attitude you're going to get on the other end of the line. Who's going to let you, I'm going to address these points, but who's going to let you talk for 30 seconds and who's going to cut you off after 7 seconds and throw off your report. Consultation is a real trick to this job for all of us. And I do think that also should not be an added stress to an NP or a PA, especially when they're newer. You need to learn it. You need to learn how to interact with a subspecialist. To your point, especially having a definitive question, not just a what do you think. Not calling too early without all the data back. On those points, I've seen a lot of things over the years that'll burn people and make them nervous to make those phone calls and whatnot. I've seen, for example, the DKA patient who comes in. I just saw this about a year ago, and a pretty seasoned NP or PA, because it happens to the best of us. You got a DKA patient, looks like DKA, smells like DKA, it's clearly DKA, and they call, for example, the hospitalist for admission. And then, you get the doc involved and say, hey, I saw this patient, they're stable, already got him admitted to the hospitalist, and you just think, boom, this is a good day, I'm on it, I feel good, the doc's going to praise me, we're going to move on. Mm-hmm. And then, the BMP comes back and the bicarb's 5, and guess what? Your hospital mandates that go to the ICU, and it probably ought to. Now you got to backtrack a little bit, right? And call the busy hospitalist and tell them, hey, congrats, you don't need this admit, and I need to call the ICU. And you got to kind of wait it out sometimes. If you don't know what you don't know, this is how you learn. I get that. But if you don't necessarily realize yet what all the pieces of the puzzle are for where you're trying to get to, ask. Hey, doc, do you think I have everything I need to get this patient consulted by this specialty or admitted to the hospital? Every now and then you might be surprised to find out, no, this one thing that's not back yet actually does play a part in final disposition, whether or not we need them. You won't know those things until over time. Mm-hmm. So whether you feel confident in it or not, it's probably a good idea, especially early, to find out, do you think I have everything I need to make this phone call?
Yeah,
simple question. Mm-hmm. And if the answer is, oh yeah, please, go ahead, good to go. You might learn a lot more than you think at that moment. In addition, there are some very unique diagnoses that come up in emergency medicine. I had a young PA a year or two ago who I'm debating right now. I don't know if any of these stories are going to involve you or not now that I think about it.
It was probably me.
It's not silly stuff. It happens to the best of us. I remember when I was a brand new attending, within the first week, I was overwhelmed at the shop that I was working at, and I remembered calling a surgeon, I'm not joking, for a diverticulitis uncomplicated, because in my mind I thought, I've got all these sick patients, they're everywhere, oh, that diagnosis is diverticulitis, I think I need a surgeon. I was just overwhelmed, and I was 2 weeks out of residency, and I called and they were quiet, and they said, oh, okay, if you think they're sick, why don't you call a hospitalist and they can consult us if this progresses. And I went, oh, right. So then I called the hospitalist and she says, so your non-perforated diverticulitis needs to be admitted? You sure you don't want to send that out on antibiotics? And I was like, oh, right. So it happens to the best of us. Yeah. This is how you learn. But if I was an NP or a PA and I said to a doc, hey, they've got diverticulitis, I'm going to call the surgeon, and someone says, whoa, we don't really have to in this case. Mm. And then you get that learning curve built. It's a good thing. You guys have that benefit, and that's great. I've had people call on epiploic appendicitis, right? Until you've seen one.
That one was mine.
I was trying not to throw you under the bus. Until you've seen that diagnosis, you don't know that nobody cares. Yeah. You might go ahead and pick up the phone and call a surgeon, and then be quiet for a minute, and then hopefully have the attitude to say, hey, don't worry about it. Or you can end up getting the surgeon who's like, what the hell are you calling me for? So
in this scenario, I did know enough to be like, I've never heard of this diagnosis before
right.
for some reason, but I knew at least not to call a surgeon right
That's fair. That's fair, right?
But that is what's unique about this job is, you do learn stuff every shift.
Every day,
and for some reason that diagnosis has slipped by me for 3 years. But
easy to do. You still hear things sometimes that you're like, I don't know. But the benefit of being an NP or a PA is to say to both a doc, and then if you both don't know, to a subspecialist, I don't know. Yeah. Again, it takes a village. So yeah, I agree wholeheartedly on assume when you're young that you may not know if that patient's ready for that call yet. You may honestly, in this field, with the things we see, not know the exact subspecialist to call. I've had plenty of sharp NPs or PAs make that quick phone call to IR, only to wait half an hour for a call back to find out that it was neuro IR. I mean, there's so many subspecialties for so many little diagnoses, and when you have, whatever, a dissection flap that's 3 inches from where those two specialties operate, ask a doc, I'm going to make this phone call. Oh, actually, that's this rare time you would call this subspecialty of that. So there's a lot to learn, and there's another huge benefit of being at that APP level where you can say, am I good to call? Am I sure I'm calling the right person? You know, is there anything I'm missing yet? And that's what is that? 15-second delay. It's okay. It's okay. And then once you see certain things enough times, there's no doubt you know, and that comes to the imaging part too. I've seen plenty of people roll through and say, there's some haziness in this area. I think I'm going to call on what seems and sounds like an appendicitis. And that 80-year-old who comes back with a rare diagnosis in that area that wasn't, and now surgery's on the phone rolling through that CT going, I don't see what you see. And you're like, well, I'm not sure I see what I see either.
Yeah.
Take a minute, get a second opinion. We're not radiologists. I rarely will call ahead unless I have a patient who's dying, a surgeon, for example, on what I think I see on a belly CT. That's a black box. I didn't go to school for 5 years of extra fellowship to read all those.
Yeah. It's
not a simple bone x-ray. You know, x-rays, same thing. I've had patients call ortho and I'm like, hey, dude, that fracture, there's nothing to do at all. It's okay. Don't waste your time or their time. They're going to get frustrated. It's late. Till you've seen plenty of these things, ask to make sure you know what you think you know. It's okay. It's okay.
Ortho is actually a big one that I've struggled with. Like, this kind of fracture, like, hey, do we need to talk to ortho about this? Can this go home? What kind of splint should we put them in? For whatever reason, every program's different. I feel like I just didn't learn or didn't retain a lot of that ortho stuff. So I mean, I still learn that stuff. And then after you've seen a particular fracture enough times, you're like, oh, that can follow up outpatient. This is the kind of splint we put them in. And then you don't even have to involve a physician at all in some circumstances.
I mean, there's so many simple things. You know, the almost supracondylar arm fracture where you're like, I've seen every humerus fracture available in an old person. I'm just going to splint it and discharge it. And that's the one time that, you just need to know the detailed physical exam. Can they feel right here? That's the only nerve distribution I care about. If you've never heard that or seen that, you don't know that it matters. There's so many details in this job. Ask and ask some more until you feel like you've seen it all. And when you haven't seen this thing, ask again. It's okay. You'll find plenty of times where the physician goes, that's unique. I don't know. Let's call and ask. That's this job.
And oftentimes that's the right answer is let's call and ask a specialist.
It's true.
Especially if you're him and Han, it's easier just to call them rather than send them home and then lay up at night wondering, should I have called somebody about that?
Right. I've said this a million times. It's like, there's a lot of times in ER where I look at somebody and I say, hey man, this is just like looking for a P wave on an EKG for more than about 10 seconds. If you're still questioning if you see one, just call it AFib and move on. That's this specialty. If you're thinking for more than 10 or 15 seconds about it, ask somebody, get some help, figure out what you're missing. Because a lot of things don't require more than 10 seconds of thought. Then that 10% of sick patients, they'll get you.
Absolutely. And I think you can kind of back down, being super conservative as you develop clinical gestalt. As you get experience, you don't have to over-order things as much. And you get to know sick versus not sick a lot better as well. And you can look at a patient and say, I think they can go home. We'll make sure a couple things look okay. But I think that just comes with time. And I think when you are new, the tendency should be to overwork up a patient and take them more seriously than maybe somebody else would.
I agree. And I feel like this is just a good time to mention, we've said several times, you yourself have said several times, even throughout this last little bit talking here, that there's a limit to your education. Now, that is a good thing to know, but there's a limit to all of our educations. I feel like this is a good time just to give a little kudos to the NP and the PA structure of education. This is not, I don't want any of this conversation to sound punitive, like you didn't get enough education. You only know this much. You guys come out with a massive scope of practice. I mean, here's the NP-PA scope of practice, and then here's the doc scope of practice. You guys have a lot of knowledge. I mean, you just look at the textbooks on the shelf and know that you're supposed to know that alone. It's more than a lot of people will ever learn for a job. So I feel like kudos is due. This is a hell of an education, and you guys have a lot of knowledge to share. It's just such a unique environment that it's worth saying multiple times. The human body, these patients, they're kind of out to get us. You don't know what they're going to do. You don't know what stage of the disease process they're in. And in the ER, we make quick decisions on limited info every day. That is a dangerous place to be compared to the ENT follow-up appointment who has the diagnosis from us, who knows what they need to worry about it progressing into. Then they get the vital signs and they take a second history. That's not us. You know, we get the guy who can't tell you everything, doesn't feel well, and came in with 5 other patients. So I think kudos is just due to NPs and PAs. You know a lot, and you're going to know a lot more that you can't learn out of a textbook. That's why it's being repeated so many times, to be cautious and try and assume you have more limits than you realize. Mm-hmm. But props to everybody who manages to get to this level of education. A lot of folks will never do that by choice, and that's fine, perfectly capable, but didn't choose this specialty. And once you do, give yourself some credit, but then know that this particular specialty and area is a lifelong process versus a lot of other areas of medicine where you just need to know what comes along with that group of patients. Right. This isn't that. That's all.
Yeah. All right. You got any other thoughts?
In general, I guess one of the other things I was going to say, you know, we could have taken this particular conversation in the direction of all these different diagnoses and how to approach them and whatnot, but I like the fact that this conversation was just about an overview on the job itself, how to approach the job, the mentality of this particular job, things to watch for, things you need to learn. That's the way to do it. It's more of a safety net that they develop all these things. You know, this is why you have an algorithm for everything, and then the expert goes completely off the algorithm. But as a new PA or NP, try and follow an algorithm. But be cautious about treating numbers in particular. You know, hey, the blood pressure's high. I'm just going to jump on that because I know the physician would want me to treat that. Not always true. You know, the heart rate's slightly high. I can perfectly well explain it, but I ought to just check a few more things. Do you really need to check a few more things, or can you truly just explain it? Sometimes you have seen enough, you do have enough knowledge to know that the number corresponds to the situation and doesn't make the situation any more emergent. So I would caution everyone young, you know, blood pressure is a great example. Let's say you are working in that super track that you mentioned. You know, I'm kind of independent right now. I've only been out for 3 to 6 months, and they're asking me to manage 6 or 7 patients over here because they're supposed to be low risk. And this individual is, you know, not all that old, no real risk factors for anything scary. They're here for something unrelated. But man, that blood pressure number just makes me nervous. You know, I mean, it's 190 over 95, and I feel like I ought to do something about it. Feel free to ask about those things instead of just jumping on them. Mm-hmm. We're in the business of treating people. Numbers can also get you burned. You can hurt people jumping on treating the numbers. You may help somebody someday, but the one time you hurt somebody and you didn't realize you could, that'll affect your mentality for a long time too. You know, worry about the patient in front of you, and then if it's just an isolated number that makes you uncomfortable in any regard, if you can't explain it, or you can but you're not kosher with it, ask for help. Get a second opinion. Come to a doc and say, hey, you know, I think I can explain this, but are you worried about that? Just ask. It's no big deal. You know, you get varying opinions, but just I think another key point, like the whole being humble and not overconfident thing, is to treat people. Don't get yourself in a position to where you think you're there to treat numbers. Yeah. That's not the right approach.
Yeah, that's good.
Yeah.
I did remember one other thing I wanted to ask you about. I've asked a lot of the people that I've interviewed about burnout. That's a pretty big topic right now, post-COVID. Everyone worked a lot of hours. We saw lots of patients. You know, people were very sick. We were all getting COVID. What advice do you have for newer APPs regarding burnout and how not to get burned out?
You know, this is a big can of worms, obviously. I'll keep it very short because I think that this is another benefit to being a PA, for example, and not a doc. I feel like y'all have a little more control over burnout. I guess that's the way I'll say that. Because of some of the things we've talked about. You have someone to ask for help. You have the ability to say, I've reached my limit in this moment. Help me with the rest of this. You know, I've hit X and Y. I can't get to Z. Help me out. I think that's one way to partly avoid burnout. Burnout in that conversation, I'll backtrack and say this. I used to tell people all the way up through residency, based on personality. I was always the optimist, the up and up guy, all the energy in the world. And I'd say, listen, man, burnout is a matter of opinion. I'm going to tell you right now, I don't think it's real. You know, you can find ways to avoid what they call burnout. It's a matter of perspective. I will admit over the years, and my wife would agree, that opinion has changed. Burnout is very real, but it's a matter of what things you let contribute to it. And you guys are in a good position versus a physician, for example, to manage some of those contributing factors to burnout. Asking for help, staying efficient on your charts throughout, not getting overwhelmed or behind, so that you're not there all night every night, stretching yourself too thin. Those kind of simple things will help you avoid burnout. I think a lot of the big contributors to burnout are, part of it's the patients that we see, the attitudes and the folks that we get. You can't help that. The ER is the safety net. You're going to have a lot of, for example, drug addicts and mental health patients that just, they abuse you, verbally and occasionally in attempts at physically. You can't avoid that part. But the inability to keep up on your charting instead of developing a structure where you hit your HPI, review of systems, physical exam, boom, I'm going to do these 3 things before getting to the medical decision making on every patient. I'm not going to have a whole bunch of one-liners with 40 notes to finish at the end of the night. I never got any further on them, but I saw everybody. Don't do that. You will burn out if you're there 10 hours out of an 8-hour shift or 12 hours out of a 10-hour shift every single time because of charting. Find a better way. If the burnout comes from perpetually worrying about what each physician's going to want you to order, ask early, get help, like we said, and work to the best of your ability, and don't stretch yourself too thin throughout your shift before you start asking for help. That will help you not burn out from the stress of always coming in every day going, oh gosh, what am I going to do with this next physician? I'm going to do what I do every single day in a structure, and they can adapt to me a bit. That's fine. There's all kinds of keys to burnout. If you don't have any, support system outside of work, any hobbies or whatnot, and work is all you got, of course, that's a problem that I may not be able to solve for anybody, but it's worth thinking about. This job's going to require you to do some things to blow off steam outside of work because it's going to build up some level of stress every shift. Find those and prioritize them a bit. But in general, burnout, I will say, I've changed my opinion over the years. It's a real phenomenon, but I think you guys have a few things that you could do to mitigate it even better than a physician. Take advantage of that, Let some of that fall aside to the people you're working with, like the doc, to prolong your career.
Yeah, that's good. Cool.
The only other thing I would say is this job is a lifelong venture for learning. Everybody calls everything in medicine lifelong learning. Man, the ER is lifelong learning. You will never know it all, have seen it all, have an answer to everything. Won't happen for any of us at any stage or education level in this game. So don't burn yourself out on listening to 27 podcasts a week and reading every article unless you just love medicine. I've been there. That's okay. But don't stay still. Patients and this profession will evolve around you and pass you by. So always try to learn one thing new per shift. Ask the questions you have before or after the shift that weren't related to the patients you saw that day. Let people know when you're young, when you come into a shift, what you think your weak points are. Ask for references to, hey, I have this, I feel like I'm just not sure about X, Y, or Z. Do you have a radiology resource or a podcast on critical care medicine that you like? You may not use them all, but ask. They're out there. And pick something every now and then that you want to learn a little extra about. If you want to skip the music one shift a week driving into work and listen to some unique podcasts on one thing, ventilator management, I don't know, anything you want that applies to an NP or a PA, do that every now and then. Broaden that knowledge base just a whiff as you go. That baseline book knowledge, you got to have it. And then something extra year on year, you got to have it because patients are getting sicker and you'll never know it all. So don't sit still and you'll do just fine.
Yeah, absolutely.
Yep.
Well, cool. Thanks for your time. I really appreciate it. I think this is going to be great for people that are new to the ER. I think even paramedics, still working in the field can glean a lot from it. But yeah, thanks for your time. I think this is a great episode. Thanks everybody for checking this out. Whether you listen to it on the podcast, the YouTube channel, or on the website. Make sure you like, subscribe, comment. All that stuff really helps me continue to do this and spreads the word, and hopefully gives some of the new APPs in the ER some really good advice. So thanks, guys. Thanks, Dr. Barito.
Absolutely. Anytime.